Okay, talking about the questions from inflammation of larynx, what we have the first question, that is talking about what write the clinical feature and management of acute epiglottitis, right? And we'll be talking about it. Now it is the recent question, that means it is asked in 2023. Now talking about the acute epiglottitis or supraglottic laryngitis. Now we're talking about supraglottic laryngitis. As we know, the different site on supraglottic, what are the different site on supraglottic region? The different site are our what? Suprahyoid epiglottis, right? Infrahyoid epiglottis. Similarly, we have arytenoid, aryepiglottic fold, right? We have what? We have false vocal cord, right? So these are the structures. Now we can say, what is this acute epiglottitis or supraglottic laryngitis? It is an acute inflammatory condition confined to supraglottic structure. Now here we have epiglottic, aryepiglottic fold and arytenoid, and there is marked edema of this structure which may obstruct the airway, right? And that is what the clinical feature that we'll be talking about. Now what are the etiology of acute epiglottitis? Talking about the etiology, right? Etiology are different in children and in adult. And talking about in children, right? In children, the most common etiology is H. influenzae, Haemophilus influenzae, and the type B1 is the most common organism, right? Responsible for the condition in children, Haemophilus influenzae, especially type B. And talking about the adult one, right? In adult, there are the broad range of bacteria, right? There are broad range of bacteria, viruses, combined virus and bacterial infection, right? They can cause this condition, but it is the serious condition, and it affect mainly 2 to 7 years of age, right? And sometimes it affect adults also, as I have already mentioned about that thing. Okay, now talking about clinical feature, right? Now clinical features are, what are the clinical features? The onset of symptom is abrupt and rapid progression. It happens quickly, right? It happens suddenly, abrupt onset and with rapid progression. Okay, and another clinical feature is sore throat and dysphagia, right? Dysphagia, sore throat, and the person is feeling difficulty in swallowing, right? Dysphagia, and these are the common symptoms that is presented in adult, right? Presenting symptom in adult. Now another important clinical feature is dyspnea, right? Difficulty in breathing and stridor are common presenting symptom in children, right? They are rapidly progressive and may prove fatal unless relieved. They can be fatal, right? Life threatening condition because of what? Dyspnea, difficulty in breathing and stridor. Okay, now fever may go, since it is inflammatory condition, itis, epiglottitis, since it is inflammatory condition, fever, obviously there will be fever, and it will go up to 40 degrees Celsius, right? And it is due to septicemia, right? Patient's condition may rapidly deteriorate. So in clinical feature, we talked about what? We talked about its onset, right? And its progression. We talked about the symptom in what? Adult, right? Sore throat and dysphagia. We talked about the symptoms in children, dyspnea and stridor, which may be life-threatening also. We talked about fever, and yes, these are the clinical feature of epiglottitis. Now moving further, now how we are going to manage this condition. Now talking about management, right? What we need to do, we need to initially examine it, right? Now before examining it, what we need to know is this is a emergency condition. It has a rapid progression, so rapid progression, and it is acute in onset. So management, what we do is hospitalization is done, right? Hospitalization is done, and before examination, right? We need to take care of some of the things, such as any instrumentation or anxiety provoking interventions, such as direct inspection of oral cavity using tongue depressors, right, should be avoided. Now why it should be avoided? Because it can lead to what reflex laryngospasm, since the individual or child is having difficulty in breathing itself. Now if we do or if we perform such activities which will precipitate reflex laryngospasm, then the condition may be further exacerbating, right? It may be further worse. So we need to avoid such instrumentation or airway provoking interventions, right? So in such condition, what we do is we do clinical diagnosis, which is obvious. So done for child for throat examination, right, or for x-ray procedures, throat procedures. As I already mentioned, it may exaggerate reflex laryngospasm. Now after securing airway and stabilization, now we can proceed for examination, right? Now after securing airway, right, and after securing the patient is stable, we can proceed toward examination. And talking about examination, right, what we can see is with the help of tongue depression, right, tongue is depressed, and the depressed tongue will show what? It will show red and swollen epiglottitis, right, epiglottitis. And on on depressing the tongue, we can see it. On depressing the tongue, we can see it. And on indirect laryngoscopy, right, it will show what? It will show edema, but it will show edema and congestion of supraglottic structures. As I already mentioned, what are the supraglottic structures? Our epiglottis, epiglottic fold, arytenoid, right, on indirect laryngoscopy. So these are the two things, right? As I have already mentioned, this examination is avoided for fear of precipitating complete obstruction. It is better done in operation theater where facilities are for intubation, right? Now what are the other investigations? Talking about other investigation, what we can do is we can do x-ray, right, that is lateral soft tissue x-ray of neck. And this lateral soft tissue of neck will show what? Swollen epiglottis, that will appear as what? Our this thumb sign, right, thumb sign. So this is one important investigation. Now we are done with examination, or we are done with precautions should be taken before examination. We're done with examination, right? Examination, we talked about tongue depressor. We'll just visualize epiglottic, how it is, right, red swollen. We talked about what? Indirect laryngoscopy, what will be seen in indirect laryngoscopy. We said the edema, right, congestion of supraglottic structure are seen. Similarly on lateral soft tissue x-ray of what? At neck, what we see our thumb sign, right? So these are what? These are the investigation, right? And talking about treatment, as I've already mentioned, treatment, there is on treatment the hospitalization because of danger of respiratory obstruction. So the hospitalization is very important. We can provide what? Immediate intubation, right? We can provide immediate intubation. After that, emergency intubation or tracheostomy for obstruction, if there is obstruction. And then what we can do is we can provide antibiotics, right? And antibiotic, what we can provide is we can provide ampicillin or third generation cephalosporin, right, since they are effective against Haemophilus influenza and are given by parenteral route, IM or IV, without waiting for result of throat swab or blood culture. We just provide it initially. We don't wait for these results to come because it is rapid in onset and it is rapid in progression and what? Our abrupt in onset, abrupt acute in onset. Similarly, we can provide steroid, right? Steroids such as hydrocortisone or dexamethasone, and it is also given what? Parenteral route, right, IM or IV, and it is done to relieve edema. It is given to relieve edema. Okay, and another is what we can do is we can provide adequate hydration, right? Adequate hydration patient, and it is what it is done through parenteral route, right? Parenteral fluid can be provided. Humidification and oxygen are also very important, right? Patient may require mist tint or crepitate, and we talked about intubation also. So what was this? This was the treatment of what our acute epiglottitis. What we can do is we can do hospitalization, we can do emergency intubation, we can provide antibiotic, that is ampicillin or third generation cephalosporin, we can provide steroid dexamethasone and hydrocortisone. Adequate hydration is important, humidification and oxygen is important. So these were the treatment, right? Treatment of acute epiglottitis. Now another important thing that is often asked is it is about acute laryngotracheobronchitis, right? LTB, that means inflammation to all larynx, trachea and bronchitis. And the easy part of this is it has same, the treatment is similar to of our acute epiglottitis. Since in this acute laryngotracheobronchitis, so we do hospitalization, we provide antibiotic, and similarly we provide here also we provide ampicillin. Humidification is important, right? Adequate fluid is important. Steroid hydrocortisone similarly, right? Here we provide additionally we provide adrenaline, since it is a bronchodilator, right? And which may relieve dyspnea and avoid tracheostomy, intubation and tracheostomy. So the more or less the treatment modality for acute laryngotracheobronchitis is similar to that of our this acute epiglottitis. Only the thing difference is that here we are providing bronchodilator also, that is our adrenaline, right? So treatment portion we can add something and we can make it. So what about other things? Now talking about other things, as I've already mentioned, it is the inflammatory condition of larynx, trachea and bronchi, right? And it is more common than acute epiglottitis. In acute epiglottitis, it was common in 2 to 7 years of age of children, right? Now what are its etiology? Talking about its etiology, here we're talking about what? We're talking the etiology were what? Haemophilus influenza B type, right, in children. Now here it is viral infection, right? And the virus is parainfluenza type 1 virus. Along with type 1 there is type 2 also, and it is mainly affecting children between 6 months to 3 years of age, and the male children are more affected. Secondarily, bacteria infection by gram positive cocci soon supervenes, right, in male child. So etiology we are clear. The age group 6 months to 3 years, right? Male child is more affected, right? And it is caused by what? It is caused by parainfluenza virus type 1 and type 2. Okay, now talking about pathology, we can read, but let's escape it. Okay, let's read it. The loose areolar tissue in subglottic region swells up and causes respiratory obstruction and the stridor. This, coupled with thick tenacious secretion and crust, may completely occlude the airway, right? That is the pathology. That means there is loose areolar tissue in subglottic region that will swell up and cause respiratory obstruction and stridor, right? Okay, and since there are secretion also, thick tenacious secretion and crust in addition may completely occlude the airway. Now talking about the symptoms, right? The disease starts with upper respiratory infections, right? Since what? Larynx is also involved, so the person there will be hoarseness, croupy, cough. The fever will be there since it is inflammatory condition. This may follow up in difficult breathing, inspiratory type of stridor. Respiratory difficulty may gradually increase and sign of upper respiratory obstruction will be seen. So these are our symptoms, and treatment we have already done with it. So now another thing is to know about the difference between acute epiglottitis and acute laryngeotracheobronchitis.